Hi, and a warm welcome to everybody rejoining us for this second session on day one of our 7th annual ISNTD Festival. We had a wonderful first session with the WHO, their perspectives in terms of role of communication in the community, and then shining a spotlight on community with the World Mosquito Program and the Medicines for Malaria Ventures Program and the WHO. Some really interesting insights in terms of community engagement. We wanted to move to the next session, which is going to be really about the creative process itself in terms of process to advocacy, whether that's disease awareness, whether that's at a campaign level, the kind of advocacy mode. And then there'll be a workshop later after this, which we'll come to in a minute. But I'm honored to be joined today by our guests. So Stéphanie Meyer and Judith Perez Gomez from Valneva, speaking about their Chikungunya disease awareness effort at the moment. And then this very interesting cutting edge presentation by Takeda Pharmaceuticals based in Thailand, the Thailand team with Phattraphorn, Dr. Phattraphorn Chunhakamolruck and Dr. Ratchada Akkarasrimachai, head of vaccines, and the senior product manager for Thailand, Takeda Thailand, looking at AI and advocacy within a dengue setting. And then we're going to be joined from New York with Ilan, the Director of Communications at the DNDi, looking at leishmaniasis, a new film that they put together, Voices for Leishmaniasis. So without further ado, without further kind of speaking about it, I think we'll move to the first speakers, which are Dr. Stéphanie Meyer and Dr. Judith Perez Gomez from Valneva. So I'm going to back everybody else out. We're all still here, but just hidden away. If I could ask you to mute your videos and your voices, and I'll hand the floor over to Stéphanie and Judith. So over to you, Stéphanie and Judith. There we go.
So first of all, thank you for the invitation. We are really honored and pleasure to be presented here today. My name is Judith Perez Gomez. I am the VP at Valneva, and with my colleague Stéphanie Meyer, which is a global medical expert at Valneva, we will be talking to you about the challenge that we have to raise awareness in the Chikungunya disease. Okay, so first I just wanted to share a few words about who we are, who is Valneva. So we're a quite small biotech company. Our focus is development and manufacturing, but also commercialization of prophylactic vaccines. And the area in which we are specifically interested is infectious diseases with significant unmet medical need. And it's in the context of this that our pipeline includes a single-shot Chikungunya vaccine candidate. And also we are working in the first probably line vaccine candidates vaccine as well. Also, why we became as a company interested in Chikungunya. So we know that it's one of the most likely virus that could emerge and spread globally. We know that the nature of the explosive outbreaks prompted the NIAID to include Chikungunya disease on the B category for priority of pathogens in the biodefense list. World Health Organization also recognized that in 2017 and included that in the blueprint of list preparedness. And with all of that, Valneva started on the research course in 2018. We had at the time the first positive results for a phase 1 of a live attenuated vaccine. So that encouraged us to move forward. Then in 2019, thanks to the coalition of epidemic preparedness innovation, we could also have a grant to move forward and to have an agreement with them. And as part of this agreement, we worked in make a transfer of competence and technology to a manufacturer for lower and middle income countries, and that happened specifically in 2020 when we could partner with the Butantan Institute, and we're very proud of having this joint collaboration and advancing together with them. Okay, so chikungunya, I know that people can be more or less familiar with the disease, but this is a disease we're talking more and more. It's becoming an increase in global health. It's really spreading across the world. We know there is characterized by acute febrile polyarthralgia and inflammatory arthritis. We know that other manifestations can join also include debilitating joint pain, and we also have all neurological complications. For a little bit of the history, it was described for the first time in 1952 during an outbreak in Tanzania, and the disease was named Kimankonde, which is a language from the Makonde tribe, which it means the man that is contorted, or also can mean like the man that can walk or stop walking. And this is to illustrate the one of the symptomology of the severe chronic incapacitating arthritis. Since the discovery and since the first identification, we have seen that it has spread it in many other areas, as Uganda, sub-Saharan African countries, and now we know that we have seen outbreaks across all the continents. Chikungunya is specific for several things, but one of them is the epidemics, which they are characterized because they are very explosive, so they arrive in a very sudden way with high attack rates, and then suddenly for a certain number of years they disappear. So it doesn't follow the most classic epidemiologic trends, and then it appears, making also the prediction and the modeling quite complicated. But also what we see when that happens is that these high attacks that happen very suddenly overwhelm the local healthcare system, and this is something we will see later, and Stéphanie will illustrate that with the Paraguay current outbreak. So just a few words about who is behind the disease. So this is a very well-known mosquito. So we know that it's transmitted by Aedes aegypti and Aedes also albopictus. Those mosquitoes are, as you know, very well-known, and they transmit other diseases as Zika, as dengue. They are aggressive, they eaters, and also it's to note the albopictus due to a mutation in the A amino acid in the A1 glycoprotein has allowed it also to become more competent in what we call less cold or more temperate climates. And now I will pass the word to Stéphanie, who is going to tell you a little bit more what this mosquito is running around.
Yes, thank you, Judith. So, as you mentioned, chikungunya was first described in Tanzania in 1952. And for the first few decades after this discovery, there have been rare outbreaks that really occurred periodically. Nevertheless, today it's estimated that more than 75% of the world's population lives in areas at risk for chikungunya virus transmission. And this is mainly due to the fact that around 2005, a mutated chikungunya virus strain emerged, leading to more readily infected Aedes albopictus mosquitoes, and this is how the virus could spread across the world. So today, transmission of chikungunya has been reported in more than 100 countries, with the areas of greatest risk being thought to be the Americas, but also parts of Africa and Southeast Asia. What is most concerning today is that modeling now shows that the problem may only get worse due to global warming and climate change. Indeed, as the Earth's temperature is increasing, we are likely to see the vector habitats to expand, which really pose an immediate risk of outbreak in warmer areas, including the United States, for example, and Europe as well. So since the early 2000s, when the disease has spread to Europe and Americas, we can see that this has been done. This has been due to viremic traveler, and indeed, since the discovery of the virus, we have seen some major outbreaks, some global outbreaks of chikungunya that have been reported. One notable event as well since the discovery of the disease is the explosive outbreak of Chikungunya virus that occurred in Italy in 2006. So it's really something that can happen very close to us as well, where surveillance systems have estimated that more than 35% of the population was infected between March 2005 and 2006. So really showing the explosive and unpredictability of the outbreak. Regarding the spread of the mosquito, we know that currently the Albopictus mosquito is present in 39 states in the US. So this really poses a serious risk for endemic transmission there as well. And it has been listed as a priority pathogen in the United States. Between 2013 and 2017, there are more than 2.6 million cases of chikungunya that were reported to health agencies across the Americas. And one important thing to highlight is really the current outbreak in Paraguay that is currently ongoing. And since late 2022, we have witnessed there a rapid surge in the number of infected individuals, which is really surpassing by far the number of cases reported in the previous year. Unfortunately, without a preventative therapy, the disease really continues to spread throughout the country and is, as mentioned by Judith earlier, really overwhelming hospital systems and resulting really in several complications among infected individuals. So this ongoing outbreak, with the increasing trend in the number of cases throughout the America, is really a concern of major healthcare organizations. So few words now about the disease. So the disease is characterized by two phases. There is the acute phase, which affects up to 97% of individuals who are infected by the virus. It's a phase that occurs within 7 to 10 days after 3 to 7 days after infection, and with classical symptoms, which are mostly characterized by a sudden onset of high fever and joint pains. There are also other symptoms that can occur, which include headache, muscle pain, joint pain, red eye, nausea, or vomiting. And usually, the acute phase resolves within 7 to 10 days after the symptoms appear. Nevertheless, the big issue with chikungunya infection is that around 33% of individuals can turn to the chronic phase, which is really impacting their daily activities and which has long-term debilitating impact on patients' lives. So long-term and chronic phase of the disease is really characterized by pain, joint pain, arthralgia, which can last from months to years. And it's well recognized so far that people who experience chronic chikungunya, so up to 43% of individuals, never return to their previous status of health regarding the physical ability, but also the huge impact that it can have on the psychological impact and the social impact. So really an important disease. So currently, there is no approved vaccines or antiviral therapy to protect against chikungunya disease, and there is no way today to defend against emerging outbreaks. The only way to deal with chikungunya is to implement a symptomatic treatment with pain relief, and this is really what is available today. In order to prevent the disease, we can only prevent mosquito bites so far, which is the best strategy. But nevertheless, even if the mosquito bite prevention reduces really the probability of being bitten, there is no guarantee to really be protected. And we have to keep in mind that one bite is really enough to cause the disease and the long-term debilitating impact. So this is what we know at the scientific community level. There is hope as well because there are vaccines in development, there are approach strategies that are being implemented, or we think about it to really fight against this debilitating disease. And I will let Judith walk you through the way we are raising disease awareness and building bridge as well between what the scientific community knows and what other people need to know in order really to have an integrated approach. And the floor is yours, Judith.
Okay, so yes, so that brings us to our initial introduction, which is raising disease awareness. So just to share our experience, as I said, since we started on our interest and the development of a vaccine candidate, one of the first things that we observed when we were talking with different people, with different experts, groups, countries, it was the different level of awareness that we were finding. That could go from people who were or who knew relatively well the disease, from people who could say, oh, Chikungunya, what is this disease? Never hear about that. Very often the difference in terms of awareness and knowledge are multifactorial. That's true that when you have faced an outbreak, that resonates a lot and that makes a big difference. But in fact, we saw that yes, even if there is a certain level of knowledge, how much we know about the disease, the virology of the disease, the mechanism is not so high. It's the same thing when we look at the consequence, when we look at the literature, there is studies, there is a lot of things that people have followed and published after an outbreak, but finally the consequence, how long is the pain, the chronics or the different complication is not always super well documented. Diagnosis is also a challenge. And it's also the surveillance system is not always super efficient from the first moment in which we can identify a first case and then we have an outbreak that goes very fast. There are areas for improvement. We see that underreporting and misdiagnosis is not rare. Co-infection may happen relatively often, specifically when you have, for example, an area which is already endemic, for example, for dengue, and then you have a chikungunya outbreak. And of course, the economical burden is really quite poorly established. So we believe it that building bridges to fight together, to treat the disease, and to put in common our knowledge, it was something we would like to be involved with. When we look at specifically at awareness in particular, because there are other areas, there are different things that we've been doing. So one of them is this chikungunya video of awareness that we just finalized. It is also, of course, all the different activities of partnerships that we drive with different medical societies. It's collaborations with, for example, live webinar like ISD, Medscape, educational symposiums. So there are things that are already contributing. But in fact, we also see the other gaps, specifically, as I said, in surveillance, in better having the data in seroprevalence, the diagnosis. Every time we discuss, we know that there is improvement in diagnosis, but there's still a lot to do. The modeling for outbreak prediction and also the educational efforts. We know that there are different educational efforts, but maybe not everybody's aware. So this is something that, of course, we will be super interested to discuss and to understand who else is working on this, who else is interested, and most of it who is interested in partnering and sharing the mutual knowledge. So with that, I will end at my presentation. Of course, if there is any questions, but in any case, we have the strong belief that awareness is a long road as for other diseases, but that's for sure together that we can improve and make this happen. Thank you.
Thank you very, very much, Judith and Stephanie, there for a very a great presentation and very honest in terms of the future. You're very much early on in terms of the disease awareness. I know that you put forward a fantastic animation that's showcased as well regarding chikungunya and raising awareness in addressing some of these gaps that you've mentioned. And I wonder how that's going to progress. Maybe these diagnostics are going to become more available as things progress. Maybe data is going to be, maybe it's a data generated approach that's going to be needed for this. These viremic travelers, these travelers' sense of responsibility that perhaps needs to be piqued and understood and channeled into communications. I'm sure a lot of this will come up in the Q&A, but thank you very, very much for that. Thanks a lot. That was wonderful. We joined with quite a few people from across the world. So so don't be shy. Put your names and put your countries in. It would be great to hear from you, from the audience as well. So from Montenegro, Dr. Nadia Stepovic from the Institute of Public Health in Montenegro, Dr. Rabio Ibrahim from the FGS Society in Nigeria. There are many, many others, so please don't be shy. That moves us to the next kind of, so from a early disease awareness landscape and approach, it'd be moving to a kind of more mature, as it were, more integrated to the market, an actual campaign. In this instance, for a vaccine that's out, everybody's talking about Takeda and their particular approach to dengue. And so we're very honored today to be joined in this session by the head of vaccines for Takeda Thailand, Dr. Ratchada Akkarasrimachai, and also Dr. Phattraphorn Chunhakamolruck, the senior product manager at Takeda Thailand, for quite an amazing campaign that's been put together called IngMar, leveraging artificial intelligence in dengue campaigns. So I think the floor is yours to go through that. So Dr. Ratchada and Dr. Phattraphorn, the floor is yours. So over to you if you put your cameras on and you're on. Okay? There we go. That's it. Dr. Ratchada, hi there. And I think Dr. Phattraphorn as well. Hi there. And I'm just going to minimize myself out. The floor is yours.
So hi, good evening from Thailand. I'm Ratchada, head of vaccine from Takeda Thailand, and I'm here today with Phattraphorn, my counterpart, senior product manager. And today we are very pleased to share you about the power of public-private partnership, what we do in Thailand to raise the awareness of dengue in the next step of the innovation. So I would like to start with the question. Which animal kill the most human? You can think from your imagine what would be the most deadliest animal in the world. And surprisingly, the most deadliest animal is mosquito. It kills more than 1 million people per year. And with this number is higher than dog, higher than snake, and even higher than the crocodile. So you can see the small bite and big threat of this animal can create a disease, many of disease, and mosquito doesn't lead only the dengue, but also lead other disease as well. But however, today I'm going to focus on the dengue. And as you may aware that dengue is very endemic in many area around the world. If you look at the heat map here, you can see that about half of the world population are affected with dengue, and especially in the tropical region like Asia Pacific, like Thailand, and also the Latin America. And in Thailand, we also suffering with dengue for more than 70 years. And even we have multiple measures with the government driven to control the disease as a vector control, but the disease still existing and the case still circulate around. And it's come to the initiative that we are developing with the partner. The goal is we want to reduce the dengue burden. And what we do is we create the dengue zero MOU. It's the area of focus that we're looking for to reduce the burden of dengue with the 11 partners to capture with the 3 purposes. And who are the 11 partners? You can see here that we're focusing on many of the key players that take important role to control dengue, because we know that the one voice is not may not very big the higher impact rather than we putting in together. So right now we have 11 partners, including the government entities, which focusing on dengue prevention and control, like a disease of department control, Bangkok Metropolitan and Hospital Administration Association of Thailand. And we also have the academic association like Infectious Disease Society Association of Thailand, the organization that focusing on improving knowledge among healthcare professionals on dengue prevention and aim to improve the better outcome. And lastly, we also have Takeda Thailand together as a private organization. So under the Dengue Zero MOU, we create a commitment together. We launched the MOU last year in January, beginning of last year. Together with 11 partners, signed the agreement together. And our mission together is we want to achieve 3 things. Number 1, we want to ensure that we have the policy in place to ensure that everyone has the same direction on prevention dengue in the effective way. And number 2, this I will focus with the team today, is about expanding the public alert and make sure that our dengue awareness go through our consumer in the right channel and very effective. And the last thing is about building the advocacy on dengue. And today we're going to focus on how we can build the effective public alert from build AI and to be the advocate in the public space. So I will pass the slide to Phattraphorn or yours.
Yeah, so thank you. So hi everybody, my name is Phattraphorn from Takeda. I'm a senior product manager for vaccines. So guys, today I will talk about dengue. As Ratchada mentions, Thailand is a very high burden of dengue. But like we are get used to it. We live with dengue for more than 70 years. So from the market research that we all know about dengue, 86% know what dengue is, what dengue awareness is. But only 25% have a good knowledge of dengue. So it means like there are a lot of gaps that people don't know about this, the dengue severities and also the disease thing. And that leads to the perception of the risk. So only 36% perceive of somebody in the household getting dengue. So this is lead to a lot of gap because if people don't aware of that list, so they not usually proactively get the protections or aware how to protect it. So what we have today to educate them about dengue and awareness and also the risk. The way we educate them and communication with them still conventional. We still have like a poster to seeing what the symptom look like, how to prevent dengue by the poster, same poster every single day. So do you think that this will make an urgency to raise the awareness of dengue? You might have the answer in the mind that is no. So I think there is an urgent need to create an innovation health communication campaign to help us eliminate dengue and knowledge gap among our society in Thailand. So here come the ideas we are creating INMA, the first dengue virtual human. INMA represents more than 1 million of Thai dengue victims in the past 15 years. So how can we amplify INMA? As Ratchada mentioned that we have the Dengue Zero MOU, which we can amplify the foundations of public-private partnership to make a huge impact and huge campaign. Because if we launch a campaign alone, we cannot make the impact. So the most important thing is to unify the dengue prevention and control as one voice and to launch an impactful campaign. So INMA, if you can see her characteristic, you might wonder why she become a girl and look like aged roughly 10 to 11 years old. This is because our national surveillance system in Thailand that we partner with the government indicate that 50% of dengue cases aged 5 to 14 years old. So that's why Ingmar looked like this and become a girl. So why we create the dengue virtual humans? Because we found the trend that the virtual influencer nowadays are trending. The social medias are very huge, like I would say huge channel to reach out to our target group and also the consumer. And Ingmar is not only telling story about one dengue patient, but a million of them. More if we can like telling the dengue story by Ingmar, we can tell many story through her, not only one story that make more relevancy to somebody in Thailand, and that will lead to higher impact that we have going to gain. So how can we establish this? So we kind of like merge the data and see the data together with the government to create Ingmar. You can see that right here, we have a patient faces that we have a consent with them to use in the campaign, and Ingmar developed by this kind of like patients. And we promote this campaign via public-private partnership under the Zero Dengue MOU to amplify dengue voice to Thailand. And as you know, nowadays, social media is a huge channel that like people use it every day, like more than 3 hours per day. So I think omni-channel engagement for both online and offline channel become very like successful that we have to go into this area. So ladies and gentlemen, I would like to introduce you our first dengue virtual human, Ingmar. Let's see the video.
หนูชื่ออิงมาร่างกายของหนูสร้างขึ้นมาจากเหยื่อของโรคไข้เลือดออกจำนวน 1,237,467 คนเพื่อให้หนูเป็นตัวแทนของพวกเขาบอกพวกคุณที่กำลังดูอยู่ว่าไข้เลือดออกใกล้ตัวและน่ากลัวกว่าที่คิดถ้ายังคิดว่าไข้เลือดออกไม่เป็นไรเหยื่อรายต่อไปอาจจะเป็นคุณ
So I would like to take this opportunity to thank you all our partner in Dengue Zero MOU to like bring us to come this far and together develop Ingmar. So that you see, the Ingmar went viral through social media like 3 weeks after the launch to reach more than 17 million views through the social media. Also for the out of home media, she reached more than 18 million eyeballs and gained a lot of engagement through social media influencer. And someone who are really want to study about dengue further, they also go to the landing page, which we are partnering with our disease department control of Thailand to educate something about patient story and something about dengue awareness in the landing page. Ingmar have also reached more than 123 earned media, not only locally, but international level. People gain attention, like people are paying attention to her and what is the movement of dengue in Thailand. Recently, Ingmar won the International Innovation Award last year on the category of service and solutions. It would be, I would say it would be a great start that we start this year toward to like gain a commitment to do something more in the next year. Not only the number we reached, but also the conversation we gain and tracking by the social listening tools. We see that we have a 3-time engagement about dengue and comment about dengue, bring conversations about dengue in the social media compared to the previous campaigns. And someone like the consumer trying to search more about dengue and mosquito to learn more about it significantly increasing. In the same way, if we look at the Google trend for the interest over time, the interest over time increased more than 2.4 times. And the baseline awareness has lived without any boosting of campaign. It means that this campaign is very impact for lift the awareness and maintain and sustain the long-term awareness of dengue. Lastly, I would like to say that in this ever-changing healthcare landscape, awareness is not enough to fully reduce the dengue burden. That's why innovation will play a vital role to support us in collectively discovering new possibilities for dengue prevention and control. So guys, please stay tuned for INMA Season 2 that will coming up in the Asian Dengue Day this year. Thank you very much.
Thank you very, very much indeed. That was absolutely amazing. Dr. Ratchada and Dr. Phattraphorn, what an amazing approach to tackling this question of raising awareness of dengue and kind of moving the equation forward. Very interesting, because earlier we'd heard about creating trust on one side, right? And then borrowing trust from this community. And I want to ask later on in the Q&A, where do you feel that lies? The avatar that's been created, the INMA approach, because it's from so many different people who are suffering from dengue. So there's an automatic resonance. And I just wonder how that's going to progress through this kind of trust building exercise to reach those communities. I think that's wonderful. And we'll come to that. But thank you very, very much for that. And joining us so late in terms of Thailand's hours as well. We doubly appreciate that. Thank you for that. That takes us to the next speaker. We mentioned late start there for late joining us from late in the day in Thailand, but a very early start over in New York. We're switching over to the Drugs for Neglected Diseases Initiatives Head of Communications, Ilan Moss. Ilan, hi there. Very nice to see you. We can see you clearly. And I think we're just going to hand over the floor. There's some amazing work in terms of a film that again is on our showcase, as are all the animations that I've mentioned earlier for Valneva and the Takeda. It's not just one input, there's several areas of our showcase, films, campaigns, all of it. It's there to be seen, but this particular part from the DNDi, we have Ilan speaking about From Neglect to Hope, Voices of Leishmaniasis. So Ilan, over to you, and happy 20th anniversary for your 20th anniversary as an organization as well. The floor is yours.
Well, thanks so much for having us. And, I think the first thing to say is I'm really doing this on behalf of my colleagues from 3 countries. So Lynette Otieno in Kenya, Manisha Sharma in India, and Marcela Dobato in Rio. Because I think this film, and I'm not going to speak about the disease. I'm not going to speak about our strategy around the disease or even our communication strategy around the disease. I'm just going to talk about a film and a series of films that we did. So I think it's always interesting to share our experiences with other colleagues. I'm saying a film and not a movie or even a video. I think a lot of us like to talk about videos that we created, but what we're trying to move towards, and I know a lot of our colleagues are moving towards, of how we can make more appealing films, long, short form, probably mostly short form, maybe medium form, in a world of TikTok, of quick, sort of low budget content. I think we all want to kick in and see how we can actually create content that leaves a lasting message, that puts forward appealing, compelling storytelling, but in a non sort of over promotional way. I think we're all really interested in that. I really enjoyed Takeda's example there of using this AI personality. It's tragic. I know I was just in Thailand, actually filming a shoot there as well, filming a short movie on dengue. So, it's really important to try different techniques to try to capture people's attention in this media-heavy world. So what we did, and I just want to talk about our idea, but I wanted to talk about this series of films and get your feedback as well, and share our experience, because what we did here was a little different. We really tried to merge the global relevance, so a film that would be relevant and speak to multiple audiences around the world, but then something that has really specific regional relevance, and something that can, I think, it's a hard question, or it's a hard dilemma to be in these days. How is something global? How is something local? Sure, language is an easy way out and say, well, we need to make something in a local language. But there's also just for different audiences, there's different messages that work better. I think a lot of us in global health think that we can sort of put out one film that will reach multiple audiences, that we can show in a meeting in Geneva, but that we can also show in a small village in the DRC. I think what we're learning is that it's important to think about all your audiences. It's important to also create content that's tailored. And with our experiment, we created one film with 3 sort of regional versions. And I just wanted to talk about that today. So the film was, it's called From Neglect to Hope. And it's really, it's about leishmaniasis. It's about a neglected disease. It's about a disease that, an NTD that doesn't get as much coverage as maybe sleeping sickness or dengue. And that was one of our challenges. How do we elevate this disease? And how do we really not only show how terrible and how destructive this disease is, but how do we talk about the hope, and specifically new treatments coming, or at least research for new treatments that's being rolled out. It wasn't easy. It actually involved a pretty long brainstorm between different colleagues. What are we going to do? Who do we focus? Do we make this an animated approach? We decided to make this approach based on characters, not on doctors. In global health, we sometimes get over focused on just the doctor. I know at DNDi we've done that as well, but we more or less we decided to focus on a nurse, on a community health worker, and on a sort of clinical researcher. And those are the 3 folks you see in this poster. So I'm just going to move to the next. Can you see this? And we came up with I think everyone can see this. Yeah, we came up with a hashtag called Hope for Leishmaniasis. And I think, for the fellow communications professionals on this call, it's interesting, why do you make a film? Films cost a lot of money. They take up a lot of time. We're really busy in global health communications. We're always juggling 3,000 different things. We don't think that you can just sort of get an agency to run out and make a film and it not take up any time from the sort of staffers. It's a very hands-on experience. In our case, and I'm sure with a lot of colleagues, you're working with vulnerable people in very hard to reach areas that you just don't want to take a film crew from anywhere, even from the capital city, and send them to, these vulnerable communities. It never made sense. It doesn't make sense now, even with WhatsApp, even with, connectivity. It's hands-on, and it's important that as communications professionals working in global health, we maintain that. I think it's not only creating better content, but we don't want our film crews running into vulnerable communities and putting cameras in people's faces, not taking consent, not understanding the time that it involves in filming these stories. So why did we launch this campaign? Well, we had a conference, which I think maybe some of you were familiar with or attended in Colombia last year. It's the World Leash Conference. It's the conference of leishmaniacs, as they like to call themselves. It's not every year, but when it happens, it's a real big moment for the leishmaniasis community, for cutaneous leishmaniasis, for visceral leishmaniasis, from all over the world, Latin America, Africa, Asia. And we wanted a film that we can also, that we could show, obviously, at the conference, that we could share online in and around the conference, but importantly, to kick off this conference and to offer sort of a coherent message to this conference. The last conference that happened, the last World Leash Conference, had an image of a woman with a veil on saying, I think, removing the veil on leishmaniasis. And we weren't too happy with that, to be perfectly honest. It didn't seem right. It seemed even culturally insensitive at times. But we wanted to kick this off with a different image, and we wanted to really focus on the folks that were these doctors, these health workers, these community workers. Instead of putting a patient up front, we wanted to talk about the people that are working so hard for these new treatments. So speaking about treatments, we also had new results coming out. So I don't know if any of you all are following leishmaniasis, but last year was incredible. There were new results that came out for a treatment for visceral leishmaniasis in East Africa. There were guidelines from the WHO on things like visceral leishmaniasis and HIV, which is a big problem in Ethiopia and India. And so we said, we have a conference, we have scientific results, or more WHO guideline type results coming out, and we really want to find a way to celebrate this, and to brand these different milestones that might just come out as a press release from the WHO or a scientific publication. So this was another, I'm giving you the background to why we made these films. And then, I'm saying another big piece, an NCE is a new chemical entity. So we are starting clinical trials for actually the first all oral treatment for leishmaniasis. It's a simple pill. Those of you that work on leash, we call it leash, will know that it's quite hard to treat leishmaniasis. It involves injections in the face for the cutaneous version, hospitalization, long treatments. It's quite difficult. And just the fact that we're starting these clinical trials very early, right? We're not talking, registration for a long time here. And it's still early, but we still want to build excitement around the fact that this is happening. So that was another point in our internal thinking. And then, as I said earlier, leash is sort of an ignored NTD. Sleeping sickness is one that, obviously resonates for a lot of people. We've talked about sleeping sickness on this at this festival before. We did a film on sleeping sickness that actually won the Grand Prix for the first WHO Film Festival, called A Doctor's Dream. I have to admit, that film, when you do something that has that much, success, it does sort of dictate everything you do afterwards. So our comms team, as happy as we are with that success, we're also constantly thinking about how we can replicate that success. And we wanted to apply this success to leash. And I say long form storytelling. What does that mean? As a former journalist, because I'm not, like some of you, I'm not at all a global health, I'm not a scientist, I'm not a researcher. Most of my colleagues come from the communications world in our comms team, or they're former journalists. And in journalism, you would, as a journalist working in a news desk, you would file short stories all day. But it was that feature piece, that long feature piece, where you could go out into the field, you could do research, you could travel, you could really go deep into a piece, was sort of the holy grail for journalists. And I think for us communications professionals in global health, it's also something that we really, really aspire to, as opposed to making, 1-minute YouTube clips with animation. Now, more and more, we're seeing more TikTok style or Instagram Reel style films that are quick and easy. We're talking more about this long form, building out the characters, building out a story, building out a narrative that you can actually use on different platforms, that you can use in a conference, that you can use in an event, that you can use at a talk. It's pretty, it's pretty different than, I'd say, 90% of what you do on your, your sort of your daily list of tasks as a global health communications professional. And we are definitely exploring this more and more. And then what I talked about earlier is this sort of new model. The problem, maybe not the problem, but one point that we received about the sleeping sickness film, yes, you showed it at the WHO, it was for our team, it was one of our highlights of our careers, to have Tedros talking about our film and to see it awarded. And in the middle of, it was in 2020, so it was at a hard time. But one thing we also heard was, does this film have relevance? Would you be able to show this film in a small community in Bandundu in the DRC, and will it be relevant to those audiences as well, even if it's dubbed in Lingala? That's a question that we asked ourselves and that our colleagues from these different countries also asked. So we wanted to see how we can improve on that and make something that also has relevance for other stakeholders. And then I'm just being annoying here and talking about films, not videos. What's the difference between a film and a video? I mean, nothing, but you could also say that a film is something, a video is sort of something you shoot and then you put together afterwards. A film is really, it's a film. It can be 1 minute. It's a little short for a film, but you can definitely make a 7-minute short film. And we're talking about scripting, storyboarding, really thinking about the narrative before you shoot, not just sort of, as we call it in journalism, running and gunning it. And we wanted to test that out as well. And I'm just keeping the slides here really simple, just to let the stories come out. But our first sort of face, and I'm going to take a step back, and the film link that I think we shared, Cameron, is just the global film. But there's 3 other films, which I'm happy to share with any of the colleagues here. The 3 sort of regional films which we made, I can send those links as well. They're all out. They all have the sort of same branding, but they're very different. And that's, I think, is what's interesting to us. The Colombia character is Juliana. And again, I know a lot of my colleagues have done this as well, but instead of just sort of a talking head and a more classic approach to storytelling, you interview someone and you film them in a lab, we really tried to break out a little more of her character, follow her personal life, driving her car, and you find out amazing things. I mean, we're so lucky to work in this world of global health, and specifically in neglected tropical diseases, because those people that have committed their life and their career to NTDs have incredible stories, and you need time to tease those stories out. And that's what we found every single time when we're making a film on any one of these NTDs. If you make it about the bug, I think you're going to lose interest because it's just another bug story. And more importantly, it's not about the bug, it's about the people. And it's not just about the patients as well. It's about these clinicians, it's about these researchers, our community health workers, and their determination and their commitment to this deeply neglected subject. It's something that is not only interesting to us in our community, but I think is interesting to the world, and that's how we're going to make films that have relevance outside of our world. Dengue is one thing; it affects millions of people around the world, and with climate change, will be increasingly affected by dengue. Visceral leishmaniasis does affect a lot of people, but we're talking thousands in reality that actually get sick. We're talking a very small number of people that actually know what the disease is. So it's different when you're making films about these neglected areas. So that's why we have decided to really focus on the people. In this case, she is a researcher at PESET in Medellin in Colombia. We found some other things out about her. She likes The Cure, and she loves dancing. And these things are hard. You obviously don't want to have a shot of her listening to The Cure in a global health film. But by spending more time and focusing on her character, it comes out. And it comes out less in the global film, but in the regional film, her personality comes out. And I think people feel a sense of, people from the region, when they see this, they definitely feel more empathy with her and with her hope for this disease, and with her challenges that she's facing, finding a new treatment for leishmaniasis and treating people with cutaneous leishmaniasis. So that's sort of our face for Colombia. Our face from Kenya, his name is Luke. If you see the film, the global film, he has an incredible story. And I wanted to dive quickly into how we found this story. This is my colleague Lynette, who's running the communications for DNDi in Africa. She had just found this one character on one of her visits, and he is a nurse, but he is a former leishmaniasis patient when he was a kid. And the story is incredible. I mean, you can see it in the film, both the regional Kenya film and the global film, which is available on the ISNTD website. He had a pretty bad bout of visceral leishmaniasis as a kid, but he was inspired to eventually become a nurse at the same hospital where he received treatment. These are just stories that are so compelling. I mean, they're like Hollywood, Bollywood, Nollywood. They're any kind of wood. You could make a full-length feature film about this. I think it would move people. So I'm showing this still as well because this was a reconstruction with under Luke's guidance. Sometimes you can't film just exactly what happened because it happened 30 years ago. So we shouldn't, as global health professionals, we shouldn't be afraid sometimes of setting up scenes of, as long as it's clear that that's happening. I think it's important. It helps get messages out. It helps create clear and compelling communications. And it also, it creates better storytelling. So in this case, this is Luke as a child. And he was talking about getting bitten by a sandfly as a child and getting visceral leishmaniasis. And this story was just incredible and powers because it's not only obviously a health worker, he's a patient as well. And finally, for India, we concentrated on Shishu. So she is an Asha. So I'm sure my colleagues from India, but also from around the world will know about Asha. It also so happened that I think it was last year that the WHO gave an award. Tedros actually gave an award to the Asha health workers in India for their role in all throughout the country in providing healthcare to remote communities and to obviously during the COVID epidemic, but everywhere. Now they play a huge role in this one region really affected by visceral leishmaniasis, which is known as Kala-Azar in Hindi, which means black fever. The Asha play a huge role not only in helping folks with Kala-Azar, but also in raising awareness in villages that are that are still endemic for Kala-Azar, and also in providing access to diagnosis and then obviously treatment and follow-up and care. They're huge. They play an important role for any really disease area, specifically NTDs in India. Asha also means hope in Hindi, so it fits our film really well. And it's funny because there are just, I'm sure my colleagues will know, there's just hundreds of incredible researchers and scientists and committed folks in India that we could have focused. We spoke with, with Manisha Sharma, who is our communications lead in India, and we decided to focus on an Asha for a slew of reasons, because everyone knows who they are. But instead of going high and focusing on, the researcher at the Leash Hospital in Patna or even in Delhi, it's important also to focus on the people that are doing the work, because for everyone, you can't deny. I mean, the outfit, the sort of just the way they carry themselves. They're like, that's an Asha. We know what they do, and we want to honor them. So our India film focuses specifically on Shishu, but it also obviously features these other voices. India, I think, is a great example as well of how do you do regional storytelling. There's so many important stakeholders in the fight against visceral leishmaniasis in India that you'd want to keep in a film, but obviously a film of just 20 talking heads and very little sort of field footage is going to be less interesting to a wider audience. So this was something that we had to juggle as well. I'm sure my colleagues here have had to juggle this. We have this great footage of health workers. How do we balance that with this footage of interviews that's more institutional or corporate? In our case, we sort of went light on obviously on the sort of institutional side for the global film from India, but making that regional film allowed us to focus, what stakeholders do we need for an Indian audience, and what stakeholders do we need to interview and include. I can't lie, it wasn't easy, but the version that was finally available in India was fantastic because it really spoke to these local stakeholders and included those interviews that we just didn't want to include in the global film because it would have cut the sort of narrative down. Then, I've been talking a lot about regional relevance. I'm sure all of you have done this in your films, but I've noticed in global health, you'll find, a French, an English, a Spanish, a Portuguese, maybe an Arabic version of a film that we make. But a lot of, at least some of the Geneva-based organizations, but it happens all throughout the world, will they think to create these really regional versions? Of course, in DRC, you might find something done in Lingala, in Kenya and Swahili, but in this case, we created versions in Pokot, which is this county in northern Kenya where this hospital where Luke works at lives. It's called Kachaliba. And our Nairobi office insisted on making, really going hyper local, taking the effort. It was not easy finding someone who could read Pokot. I can't lie, obviously Swahili you can do in 2 seconds, but these regional languages, no. We also wanted to make it regionally relevant. So for Ethiopia, we made a version as well in Amharic, and that, that's easier. That's a much more widely spoken language, but it's this thinking about making something that's specifically relevant to these different regions. And for leishmaniasis, it affects Kenya and Ethiopia. Ethiopia is hugely affected by VL, and just making it in that language instead of just doing it in English, maybe with dubbing or something, was a huge step. And I think we saw a lot more success from that. And then I wanted to talk about how this sort of character-based storytelling works. And we've always found this, this is the second time. It always sounds like we're always doing this. When we made the sleeping sickness film, we focused on this character, Dr. Conde, who is the principal investigator for our sleeping sickness trials in the DRC. That film, as I said, it did really well. We had an event in New York where we showed the film. There happened to be Sharon Stone and Anthony Fauci at the event. This was before COVID, but that still created some sort of celebrity power. The branding and the press work around that film sort of elevated Dr. Conde to a new level. Someone created a wiki page for Dr. Conde. We didn't do it. It just happened. This sort of branding and just focusing on this one character and his story was able to elevate that. And we saw this for our film on Luke as well. So that's Luke, who I spoke about earlier. Doctors Without Borders, or MSF Norway, did a telethon this year. It's this pretty important telethon that happens every year around charity causes in Norway. And MSF and DNDi, for those of you that know DNDi, we're the sister organization of MSF. They created us. We teamed up to be the sort of the recipients of this telethon campaign in Norway. And the folks at MSF saw this film. They saw Luke. They understood the sort of branding around his story because the film was so clear. And they asked for him to come to Norway to be sort of a special guest. And this is not a DNDi person. This is not one of our staffers. This is a nurse working in a hospital where we run clinical trials. Luke went to Norway. He did TV interviews. He went around with, I wasn't there, but there was some pretty high level MSF and Norwegian government folks. They go around to doors, they collect funds. It's a huge event in Norway, raises lots of money, lots of awareness around these diseases and these organizations. He had never been to Norway before. I think he never left Kenya, but I need to double check on that. But he certainly had never been to Norway. And wasn't easy at first, I think, for any one of us to get on TV, but he did fantastically. And through the film and seeing him on the film and seeing him in real life, that just makes such an important link for people. And the film wasn't just sort of about a global health issue with a bunch of talking heads and some graphics like we kind of see with a lot of our global health films, as we always made global health movies. It was really the story of Luke. And that's so impactful to focus on these stories. And I'm winding up pretty soon, but I just wanted to talk really briefly about what we learned. We saw Hope for Leishmaniasis as a hashtag that actually was used by other folks, which was great. I can't say it went viral. I included a few tweet screenshots there of folks that used the hashtag, but we were able to use this branding. So these three clinicians, these three heroes of leishmaniasis, even during these milestone events that happened last year. So there was a new HIV/VL treatment, which I talked about, new guidelines from WHO, results published in a scientific journal. Every time we were able to rely on these images, these sort of narratives based around these three folks, which you can see in the word, sort of the whatever it's called, the word blob over there. You see Shishu, you see Luke. These names came out, and that was just proof for us that it's stories that really matter. We spend so much time thinking about social media, but I think we need to think also about with these long form films. No one is going to click a 7-minute film and watch the entire thing on Twitter now. People don't have that attention span, but that's okay. I think we need to think about the longer form venues, be it film festivals. I think, Cameron, you had folks from the Health for All Film Festival from WHO on this call. That is a gift to us. As an ambition, something that we can make films for. People make films for the Oscars. People make films for film festivals. We should be thinking about that too. You want to make something that can get an award. You want to be recognized, and those festivals are a really important part of how short film makers these days get their pieces out, because people don't go to the movie theater anymore as much. So we can even be thinking about other platforms, be it Netflix, be it Canal Plus in French-speaking countries. We are thinking about those things, and I think we all should be, and getting our messages to a wider audience. And I just wanted to also show a few photos just from the events that I spoke about. The World Leash 7 went really well. That event happened in August. Those images, even though the film was just barely finished in time for the event, those images were peppered throughout that conference. The images of Luke, Shishu there, and then obviously the films were shown, and it was great branding for the festival. And for me, a pure example of regional relevance was the India film. So this is in January for the World NTD celebration in Bihar, which is in the north of India. It's the most endemic region for Kala Azar in India. The India version of the film was shown at an event honoring frontline heroes of NTDs, as you can see in these images. And those are just a few, screenshots from the film. It was very well received. People really enjoyed that, just pure, Yet we didn't show a film that focused on those other countries. We showed a film that focused on the heroes, so the ASHA workers, but then also, putting in those key stakeholders. And it was worth the effort. It was really well received. There's no doubt there. And then just a few thoughts, and I don't know if we have time to discuss, but just a few things that I mentioned, social media versus short films, how we shoot these. Shooting, meaning, how we film these. Is it more of a run and gun? You go and you sort of collect the content, or do you think about more scripted shoots? Obviously, cost and time are huge factors behind this. And then how do you tease this out in the press as well? And then film festivals, which I discussed, and specifically the WHO Film Festival. But those are just thoughts. If we have time for discussion, I don't know if we do. And that is it. Thank you.
Thank you very much, Ilan, for that. 1 second. I'm just going to stop this slide. There we go. And then we can come back. So thank you very much for that.
Sure.
What a really in-depth look at your approaches and some of the thoughts that come out of that and some of the future-facing kind of activity that you're planning out in terms of these format changes and all this kind of stuff. Really interesting how personal your approach is. You saw the faces of Colombia, the faces of India and Kenya, and how much of that enters into the filmmaking process and thought. And I think that'd be an interesting point to kind of to bring up on a little bit in terms of the Q&As. If I could ask, so thank you for that. Firstly, Ilan, thank you very much. If I could ask the other panelists to switch their cameras back on, we've got it here until about 12:55 before the workshop thing starts. If I could ask Stéphanie back, Judith back, and Dr. Ratchada and Dr. Phattraphorn as well. Brilliant. I think we're all back, so that's fine. We'll just wait for Ratchada as well. So firstly, thank you very much for those presentations. Disease awareness, I think, as a tool to then build trust, because that's in a way what we're talking about. And what I wanted to ask, the first question is actually going to go to Takeda, really, and then I'm going to put this question to everybody. Earlier we heard in an earlier session that we talk about building trust, right? Trust in that patient group, trust in those communities. Yeah, and you said earlier in your presentation, and this is addressed to Dr. Ratchada and Dr. Phattraphorn, that dengue awareness is very low in those communities, and though it's a highly endemic region, right? What I wanted to ask you is that in your approach, we heard earlier that building trust is one thing, creating trust, but there's another concept, borrowing trust, right? And then using that to reach into the community. So from a borrowing trust perspective, how do you think Ingmar does that in terms of its credibility, its resonance with those communities, and how does that lend itself to propelling disease awareness towards action? That's the question. So Dr. Ratchada or
yes.
Dr. Phattraphorn,
Yeah, thank you for your question. And I really like your word of the borrowing trust. And I think it's spot on in terms of what we building, because it's something that we need a trust partner to work together with us to make the impact of the campaign more bigger. That's why the DDC and Bangkok Metropolitan Administration play a very critical role to reach border in terms of voice of the campaign for us. So I think it really very helpful and very impactful.
It really helped. And I think when you said impactful, I think that you mentioned that on launch it was 17 million views. Is that right? That's quite a phenomenal thing. So in terms of building on that, where do you feel that's, well, what are you, without wanting to know your full strategy on that, but where do you want to take that to? What I'm trying to say is, will you be able to integrate the Ingmar with, let's say, not advances, but progression on disease surveillance, let's say data-led effort, citizen science data-led efforts, as more data is generated in the background or in these communities, will you be able to integrate? Would you have plans, or do you have plans to integrate Ingmar to that?
Yes, actually, together with the Ingmar story, we already have the burden of the surveillance report behind. It's collecting by the government, right? And what we do is we also merging the Ingmar to telling the burden of disease and during the period of ASEAN Dengue Day. And what the next step for Ingmar, actually, because Ingmar is a representative of the dengue victim. So what we plan is today, she's going to come back again for the ASEAN Dengue Day 2023 in the June, mid of June. And it will be more the story, that more emotional connection that we're working with the based on true story. It will be like a short film, like you mentioned earlier, and what we think is it will be more impactful to create a call to action that people seek more actively ask for the prevention. So this is our plan.
That's fantastic. So moving it into this actionable phase, yeah, that's a very interesting use of that particular tool, and obviously very innovative. So thank you for that answer, Dr. Ratchada. Let me flip that to Valneva for a second, to both Stéphanie and to Judith. I say this because you're very early on in that disease awareness. We have your animation there, and we wanted to, it's on our showcase as well. It's really about, and you highlighted it beautifully in the beginning of your presentation in terms of the gaps, right? And so I suppose what I wanted to say is, how do you see that progressing in terms of, let's say, borrowing trust? Because what I'm trying to say, or building trust, even in this case, perhaps building trust, because you're talking about viremic travelers as being a disease reservoir, right? How are you looking to tap into this sense of responsibility that once they've been bitten once, it's slightly different to dengue, they've been bitten once, they are a disease reservoir. So when they travel to different countries, they are a disease reservoir, for want of a better expression. How do you tap into that sense of responsibility?
Yeah, that's another way a difficult question, and as you said, we're still quite early, because when we started and we start discussing with different partners, although some of them have a great knowledge, but because they work on the field or they've been exposed or they face an outbreak, there is still a huge gap. So for us, it's I think it's like two fields we want to have to be working in parallel, and that's why it's so important, the different partnerships, because when we talk about prevention of mosquito, it's not just one measure. So it's like it's different partners, because it goes from really improving the diagnosis, but it's also what you can do in terms of prophylaxis, is the mosquito prevention, is the surveillance. Yeah. So we believe that in one side, that's for sure, that there's a lot of movement around the mosquito, in which we can probably mutualize and join, because that's one of the first things we discovered, that said, okay, Chikungunya has a lot of commonalities with Zika, with dengue, so they already started that movement, so probably we can join that movement, partner with the same actors, rather than trying to create another thing that could be completely aside. And that is working, I would say, very well, because it's becoming more like an integrated approach, and it's resonating a lot. And then when it goes to, as you say, the surveillance or the importation of cases, that's something that probably due to COVID is easier to explain, because we have seen that we are looking at prevention to prevent disease, but also to avoid importing of the cases. Yeah. And we have seen this with the Paraguay, for example, outbreak. We already have first cases in Europe. Things get not going to an outbreak. So this goes also through the work with the health authorities, and it's really linked with the surveillance, because I mean, if we want to be able to do something, surveillance is going to be a critical part, early surveillance, and the communication of this data between different countries around the world and the different partners, because we see a lot of isolated working groups, but I think we have to make sure that all of that is shared.
That's a great answer, Judith. Thank you. And just flipping that to Stéphanie for a second, I think, and just building on what you just said about disease surveillance, you mentioned, I think it was in your early slides, that there's a very low RDT, rapid diagnostics available. Obviously, very low point of care testing as well. There's a whole issue with that there. As that begins to resolve itself, and I say this because we've had submissions from people like Co-Diagnostics, companies that are really into, other companies that are into, actually, we've got Find speaking later, people are developing diagnostics, that's going to increase. So that data is going to increase, right, as well. So my question to you is, do you think your future direction in terms of getting close to this community is going to be more data-led? You've got an animation right now for disease awareness. Will you be looking to get into film or further animations, or be using a data-led approach? It's a big question, but that's definitely,
Thank you very much for your question. And for sure, we would love to be able to do things that are more data-led. But for that, as mentioned, we need more data. And this is really what is lacking so far on chikungunya, because there is a lack of easy diagnostic tools. That there are diagnoses which are reliable that exist, but which are difficult to implement. So that's why we are missing data. And I think that starting with raising disease awareness as well would help making people think about this probable disease, because as mentioned, it's transmitted by the same vectors as other diseases, so that they have similar symptoms as well. So sometimes we do not go until the lab diagnosis of the disease. So having easier tool to implement would really help to enhance surveillance as well. And this would help as well then in the future to have data-led animation. And maybe what is important as well is that our community should share as much as possible what happened in the past with outbreaks which are explosive, to really show that this exists, that this can happen, and we never know when it will happen. So I think it's really important to bring that as well. We know that it will come back. We don't know when, but we know that it will come back.
That's fantastic.
And if I may add to Stephanie's comment, in fact, one of the first comments that Pao made during the chikungunya outbreak now going in Paraguay, at the very beginning, is that they talk about the number of reported cases, and they stated if we are seeing that, it's because it's probably 10 to 20 times more the number of cases.
Yeah.
Which means that the spread is already like super fast. So.
Oh, that's a fantastic answer. Thank you, all of you, for that. Just moving from this, just like picking that out a bit in terms of community of practice. That's in a way what you're alluding to, right? Dr. Ratchada, you showed a beautiful slide with lots of different partners at the government level, municipal level, right across the board in Thailand, and how they'd input it in. And yourselves, you're talking about from Stephanie and Judith's perspective, a community of practice that's giving you this kind of almost credibility, really, that you can then go to the community. I'd like to flip that to Ilan, because Ilan, you're all about the community, right? You've taken it very personalized. You put faces on there in terms of you've talked about patients and everything. How would you marry the two things? Yeah, you've got on one hand these big partnerships that that are there they have to happen. Then on the other hand, you've got the community. So how would you marry the two?
I mean, I'm just gonna, from a purely storytelling perspective, when you're working with communities, in our case, it's communities affected by NTDs. So in pretty rural areas, where you might have differing, obviously lack of literacy, issues like that. The most important thing is taking the time to to know these communities, to be in touch with them. That's where, that's not going to be me doing that. It's never been me at DNDi. That's why I mentioned, my regional communications colleague. So Lynette has those links with Luke and the community. She speaks Swahili to him. She doesn't speak Pokot, but that has always been essential. And that's why, I love DNDi, because we have those, we just don't have the Geneva office, or in my case, the New York office. In Latin America, it's Marcela in Rio, who's actually Argentinian, so she speaks Spanish, and she has those links. I just got back from Brazil. And WhatsApp is a great tool there, where she's able to speak through voice notes with a woman with Chagas disease living in a very remote area. The DRC, it's the same thing. Once you leave the town, people don't, once you leave Kinshasa, people don't speak French. They'll speak local languages. So it's built on respect and I think, and not just running and gunning, as I said. It has to be a long-term investment where you just don't run in, take people's consent and film them and leave. There's a back and forth. I don't think it has ever worked to have that approach, because you're just not getting there. And then that's not community engagement by any means. And a lot of times with us, so in the DRC, we're filming these pieces through our clinical trials. So they're recruiting patients for sleeping sickness in these small villages. They have to consent them. No one reads. So you have to have the local health worker who, as I said, French won't work, Lingala won't work. So you need to speak another level down of regional language, which in Bandundu is Kikongo. So it's really, it takes a lot of effort and commitment to work with these communities. And as communications professionals, you need to spend that time. I think it's super important.
That's a great answer, that kind of local feel to things and that listening and that respect platform that you've mentioned to bring those communities in. I'm going to flip this question back to really Dr. Phattraphorn, because you've been very quiet and you've got away with no answer. So I'm going to come back to you on this. What I'm going to ask is, Ingmar, you had mentioned this kind of call to action. I think Dr. Ratchada, you also mentioned this for us with the the ASEAN Dengue Day, 15th of June as a master. Do you think vector control activities within those communities are going to be anything you're going to look at? I totally realize it's a vaccine, right? But I'm just saying there is activity at vector control level that those communities are definitely doing. Will Ingmar tap into that? Dr. Phattraphorn or Dr.
Yeah, so thank you for the question. I think from our perspective, actually it's not about vaccine only.
Yeah.
We would like to see the holistic view about dengue prevention and control, which like vector control is playing an important role recently before vaccine coming in. So what Ingmar said is like raising risk awareness in the society, especially target group also in the school, or maybe like parents and community. So I think it's a holistic view. Vector control play an important role. Yeah.
That's a great answer. Thank you for that. I mean, there's another spectre here which we highlighted in November. We had a two, and lots of people obviously talking about it, but we had our own 2-day meeting on climate change and the effects of this on these diseases, especially the vector-borne diseases, and the communities themselves, whether it's through, in emergency settings or all sorts of stuff, adverse climate events, all of this kind of stuff impact to the community itself. So in film, and I'm going to ask this to everybody really, but these kind of issues, right, the real community issues that are quite away from the disease, but they are real world problems for people in those communities. And we're talking about resonance, talking about trust, talking about credibility, and getting a lived experience out, as Ilan was saying, on that kind of platform to make it real, right? How much of that those kind of issues are you willing to bring into films, even though the disease is central or there's an intervention that's central, right, as an objective? However, how much of that are you going to bring in? I could ask that to perhaps Valneva first, and I'll push that or out to all of you. I'm just going from my right on my screen. So Stephanie and Judith, I'll ask you that.
Yeah, maybe it's true that climate change has a huge impact on the spread of the disease, and I think this should be brought into all the assets and everything that will be built to really show how this has impacted how the viruses and diseases are expanding. Because it's true that years ago in Europe, for example, we didn't care about Albopictus mosquito because we didn't have. Now we're starting to see the vector. We have to make it clear that once there is the vector, the risk is really there to see the disease as well. And I think it's important to see how this evolves and to show that climate change does not only have an impact on the fact that it's, that we have less water, less rains in some countries and so on, but it also has a much broader impact, which has a huge impact on health as well and on mosquito-borne diseases.
That's a great answer. Judith, did you add anything to that? Or?
No, absolutely. In fact, it's, as we see, climate change is very broad, and as many of the experts say, now the question is not like it was in the past, that it was like, would it be possible to have an outbreak? Like now the question is more like, when this is going to happen. We have even seen with albopictus how it's becoming more competent and adapting better to temperate climates, when X years ago we believed that was not possible. So finally, when this big chip is going to happen, this is something that is really something have to be very closely monitored.
So bringing that into the kind of messaging that you're going to come up with in terms of future directions for your films, I totally respect that. Ilan, in terms of an indirect measure of climate change, it's really easy to bandy around, I suppose, the term climate change, but the indirect impact of it, camps, let's say flooding in an area, displacement of people, all of this is going to result in re-emergence or in certain areas, or kind of an uplift in that disease itself, in the number of people suffering from that disease. Leishmaniasis definitely springs to mind in that. I'm thinking about refugee camps in the Middle East. We've documented that in the past in terms of the rise of leishmaniasis in Lebanon, as I know you've been out there yourself. How do you bring that into a film? How would you bring that? It's a very, is that something you're thinking of or looking at?
Yeah, I mean, we've done it with dengue. We just tried to do it with dengue in Sri Lanka and in Thailand, actually. I think we need to avoid again, this is purely from a communications perspective, but avoid the trope of, the CNN report of, the newscaster saying, there's flooding here or flooding there. I think we need to get into something a little more, a little more personal. I think a little more engaging. I mean, that being said, it's all about visuals, right? So I mean, yes, we were in Bangkok and we went around for a day with a local photographer looking for flooding. But does that really talk about just by showing flooding, what does that really show? I think you need to have great people that can really make that link, and that you're scientists. I mean, we're lucky we have Dr. Nalika as our head of her dengue program, who's one of the most compelling spokespeople out there for dengue, and we rely on her. We rely on her personal view instead of that news clip, or instead of that just more classic example of filming flooding. We just rely on her voice, and sometimes that's all you need. So I think identifying those people that can make the link is strong.
Brilliant. Dr. Ratchada, I mean, obviously we're going to ask that kind of question, but there's a slight tweak on that question. Because it's an AI approach, it's got a predictive kind of vibe to it in a sense. And I was in Singapore myself. We went to the this outbreak preparedness center next to Duke, in Duke Medical School, next to the Ministry of Health. And that whole ASEAN movement towards this preparedness, the pandemic treaty, all of this kind of stuff. How much of do you think you're going to align more Ingmar in terms of the predictive capacity that's being built for disease preparedness and outbreak management? Is there a role for Ingmar in that?
Yeah, that's a great and very interesting idea. Thank you for that. And to me, I think it's really possible to develop further, because right now Ingmar just a consolidation of the past people who suffering from dengue, right? But if we can bridge further for her role to make awareness, and in terms of to prevent her face is changing to another version because more people are suffering from dengue, something like that. I think it's a very great idea, and thank you for that.
That's a very interesting. I'd love to see that evolution, because it is a resonance that you've built, because they are suffering. It is a community of people who have suffered from dengue from all walks of life. So I think that'd be very interesting to see how those things converge together. I'm being told that we're right at the end of the time, and I'm going to get in a lot of trouble if I stay any longer, because we've got a workshop after this with Cloud9 Media, who they produce the Mectizan donation program footage films for Merck MSD in the States. And they've got a special workshop that's going to start apparently now. So I'm going to get a lot of trouble. I would love to further this conversation. I'm going to be in the ASEAN Dengue Day personally myself in Bangkok on the 15th. We have our World Dengue Day activity as well. I was there at the last one as well. Beautiful place. And I'm sure we'll meet Dr. Ratchada as well as everyone else who's going to be there. And I'd just like to say thank you all very, very much. I hate saying goodbye, but for now, it's a pause. And we're going to, you guys have to come out or I can minimize you, and we're going to move to Steve Maud and his workshop. But thank you very, very, very much. All right, for a wonderful presentation.
Thank you, everyone.
Thanks a lot.
Great to see you.
Thanks a lot.
Thank you very much.
so much.
Thank you.
Thanks.
Bye-bye.
Bye.